Appreciate it. All right, good morning, everybody. Oh, yay, we got replies back. Everybody's awake then. That's awesome. Maybe we're going to have a chatty crowd today. So we're going to go ahead and get started. All right, thank you for being here. My name is Lisa Gerardo, and I'm the Suicide Prevention Coordinator here for the facility, and I'm going to let my colleagues introduce themselves.
Hello.
Is it on?
I'm Sheila Smith. I'm the educator for mental health and rehab.
And I'm Carolyn Lightfoot, and I'm a hospital educator and simulation nurse.
Great. All right. All right, thanks. We're going to go ahead and get started, and I wanted to give you guys a little bit of background of exactly why we're here doing this. We're going to be learning about how to respond to veterans who are in some sort of distress and how to make sure that they can be safe, what to do with that. That's, of course, an important skill set for any of us to have. You know, no matter what area we work in, there's always the potential that we could have somebody that has some sort of a need. So we want to make sure we're really clear on how to handle that and that we have some sort of a comfort level on what to do when this happens. But the other reason why we have put together this training is there was an incident earlier this year where there was a bit of a misstep with a veteran. He's safe, he was always safe, everything is fine, but it generated a root cause analysis. And if you guys have never participated in a root cause analysis, what you're looking to do is look at what happened, figure out where the bumps were, and then see if there's some things that can be changed procedurally, that way that we handle situations and do things that would prevent a similar situation occurring in the future. And so one of the things that came out of this root cause analysis is that there was a fair amount of confusion on what to do when you identify a veteran that has some sort of distress, you're concerned for safety, what is it that you can do? And so what is going to be happening as the official action from that root cause analysis is an ongoing series of mental health drills in all areas of the hospital, not just clinical patient care areas, but in all areas of the hospital. And so when we were tasked to figure out how to proceed with these mental health drills, one of the things that we agreed upon is that it wasn't fair nor very efficient to drill people on something we've never taught them how to do. So that's what we are doing here. So we have multi-purposes here with this training. One, just to give you the basic skill set that everybody should have anyway working here, but also to prepare you for the drills. All right, a little bit of housekeeping as we start. This is usually the way I start any of my presentations because we are going to be talking about suicide and we're going to be talking about some specific things and specific risk factors. Suicide is a much more common issue than I think most folks realize. And so whenever I have a group that I'm working with, the odds that somebody in the audience has known someone that struggled with suicidal ideation, had attempts, perhaps even died by suicide, the odds that I have somebody like that in the audience are pretty high. Whenever someone is engaging in suicidal behavior, there are dozens of folks that are affected by one person's behavior. So it's very high that you guys will have had some sort of connection with this. So I always like for us to remember that the purpose of this is to be instructive. It's to provide some guidance and education. It's not meant to be traumatizing or upsetting. So what I'm asked is that if at any point during this, if you're having some emotional reaction, if this is difficult information for you, that you kind of give us a signal and let us know because we want to make sure that you're okay. Okay, we don't want you to leave here with some sort of heightened emotion and not have a chance to get that resolved. The other thing I'd like to point out on this slide are a couple of phone numbers. This number right here is the Veterans Crisis Line number, and I hope you folks have seen it before. It is also the National Suicide Prevention Lifeline number. Our crisis line is part of a network of 165 crisis centers, And so it's all the same phone number. So anybody, anywhere, you dial into this 1-800 number, and then our veterans are directed to press 1 to get to our folks. But this is a neat way that it is all consolidated and you don't have a million different crisis numbers. Do you have a question?
Do you have any more of those little cards that have the phone number on them?
I got cards all over the place. I don't have them here, but I can get them to you. We got tons. We love those cards. So, the other number I want to point out is our Employee Assistance Program. A lot of people are less familiar with this phone number. We used to handle employee assistance in-house, but now we contract out. And so I want folks to be aware of this number if there is a situation that arises where you need, as an employee, some additional emotional support, behavioral health support for any kind of situation. So briefly, I want to go over what our goals are for today. Of course, the first thing that we're going to want to do is we want to make sure we know how to recognize distress in folks, to recognize upset and potential risk. We want you guys to learn some techniques and some strategies of what to do when we identify these folks and how to assist them. We want to make sure everybody knows where the mental health resources are in the VA, because they're all over the place. So we want to make sure that you all know where to find them. And then, of course, the bottom line, too, is that we want everybody to have the skill set necessary, that you know what to do, that you're able to respond when the mental health drills come to a location near you. All right. Suicide prevention is everybody's business. Has anybody heard this phrase before? Good. I've got some heads nodding. This is the VA's philosophy in regard to suicide. That it is not just the responsibility of a suicide prevention program or a mental health provider, but we all have a role in this in making sure that we're keeping our veterans safe. I'd like to challenge you all to take it beyond the VA walls, though, and to change the way that we view suicide, the way we take care of people in general. As I said at the beginning, it's a much more prevalent issue than a lot of folks realize. And one of the things that we find with suicide and mental health in general is there's a fair amount of stigma associated with seeking help or identifying that you have that kind of concern. Suicide kicks it up a notch. There's shame, there's embarrassment. Those are pretty common reactions and views towards thoughts of suicide or any kind of suicide behavior. And the problem with that, in addition to the fact that just feeling shame feels pretty yucky, is that that is a direct barrier to folks being able to seek the help that they need. And so we need to start thinking about suicide as a public health issue. You know, it affects everybody. And we need, I think we've lost our feed over there, and we need to be able to change the way we as a society are thinking about suicide and remove that stigma. We need to be able to normalize it, okay? So think back about 20 or so years ago, those of you that can remember back that far. Agencies, businesses, hospitals start having things like health fairs. Do y'all remember all of a sudden everybody was having health fairs? And you were doing things like getting your cholesterol checked. That was the big thing. Well, years before that, nobody really talked about cholesterol levels, and we didn't have any idea what part it played in our health in general. And then all of a sudden there was a fair amount of education. There was a recognition that this was an item of concern. It was a contributing risk for health factors, and if people would do things differently, then you would have better outcomes, right? So all of a sudden, everybody was doing health fairs, and you would get your cholesterol checked. And now, even when you go to health fairs, that's common. You walk in, oh, the cholesterol check's over there, this is over there. What I want, what is my fantasy, and I would invite you to join with me in my fantasy, is to get to the point where the thought of emotional distress, suicide risk, any of these kind of things is thought of as just another piece of our whole body health and well-being, and that we go to these health fairs, and while we're saying, hey, did you get your cholesterol checked? The next person's saying, yes, did you go get your depression screening? And it's not something that we think that we need to be embarrassed or ashamed about. So that's my fantasy. I invite you to join me, and hopefully we can help make that a reality. So I want to give you some statistics. Anybody that's ever heard me talk before, I usually start with a fair amount of statistics because I really want folks to understand the scope of the problem here. And so suicide, as I said, is a significant issue. There are over 42,000 deaths in the United States every year from suicide. It is the 10th leading cause of death in the United States. And this statistic, that ranking, that's been consistent for years. We've been at 10th for years. Homicide is 17th. We are killing ourselves far more frequently than we are killing other people. But on the news, what do we hear about? We hear about homicide, we hear about crime rate. You don't hear about suicide. The only time you hear about suicide is if a celebrity has died by suicide. And then there's a lot of, a flurry of activity, a lot of media attention, and then poof, it's gone. Okay? So it is much more prevalent than we realize. Every 12.3 minutes, someone will die by suicide. So in the time that we are here this morning just chatting, in the United States, we will have lost several people in just the time we're here. If you think that's a lot, those are deaths by suicide. Now let's look at some numbers about attempts. Nearly 1 million people every year make a suicide attempt. That averages out to one every 35 seconds. Every 35 seconds, someone in the United States is feeling such a level of despair, such emotional distress, that they feel that their only option is to try and end their life. That's huge. That's huge. There are some differences in the way men and women approach suicide. Women make attempts far more frequently than men do, but men die by suicide more often. And this, too, is a statistic that has stayed stable over years and years. What's behind this is pretty much the method that folks choose. Men are much more likely to choose firearms, which are not forgiving, whereas women are much more likely to choose another method, such as an overdose with medication. With that, there's a far greater likelihood that somebody can find them, make sure that they get medical care, and then they survive. So that's largely the difference there. But one of the things I want us to tune into here is that the women we see and the women we work with are by definition veterans. So at some point, they have been trained in the use of firearms. So our women are vastly different from the women in the general population because of that. So I don't want us to discount firearms as a concern for our women because of that. Let's go through some definitions so we have an idea of what we're talking about. Suicidal ideation, that's the common term that we use. It's often shortened to SI. So if you're in charts and you see things that's referred to as SI, because we got to turn everything into an acronym, okay? So that's what we do. All ideation means is thoughts, all right? So this is somebody who's having thoughts of suicide. Y'all, folks cruise around all the time having thoughts of suicide. There are some that the thoughts just kind of flicker in and then they're gone. And then there are some folks that the thoughts are just chronic. They're just always kind of hanging out in the back of their mind, all right? But an important thing for us to know about thoughts is that's what they are. They're just thoughts. They do not have to become actions. So think for a minute. I want you to think about all the thoughts that run through your head during the course of a day. Would you want them all to become actions? I mean, really think of some of these, okay? I have 2 teenage boys, okay? My 17-year-old, we are now on truck number 3. It is a really good thing that all my thoughts don't turn into actions, right? They have no idea how close they come on a regular basis, right? So this is important to realize that. And it's the same with suicidal ideation. Thoughts do not have to become actions, all right? But they're distressing. They're distressing in and of themselves, all right? So we usually classify them into 2 categories, active and passive. And so active thoughts are the one that have some sort of a plan attached to them, like I'm going to jump off a bridge, I want to take all my medicine, those kinds of things. Passive thoughts are the thoughts that are like, this example, I wish I would just go to sleep, never wake up. I wish I just weren't here anymore. You know, there's not an action or a plan associated with the thought. They just wish they didn't exist. Okay? But both, no matter which type we're having, both indicate a fair amount of emotional distress. And that's the way we view suicide, behavior, suicidal thoughts, as a symptom and an indicator of emotional distress. And so when we've got folks with thoughts, we want to take it seriously, and we want to get them connected with somebody who can help them with those thoughts. A mental health professional is someone who can work with that person on how to manage these distressing thoughts, to talk to them about what's going on that's contributing to this, what is happening in your life, how are you feeling when you have these thoughts, how do you respond to them, what are some things that we can do and put into place so that those thoughts don't snowball, get out of hand, and then actually do become actions. Okay, so we take suicidal thoughts seriously. We get them connected with folks that can help teach them how to manage that level of distress. The next thing I want to talk about is suicide intent. When you have suicide intent, it's someone who has a thought and a plan, and they are planning on taking action. So we are still in thoughts. Nobody's done anything yet. But if someone actually has intent, we're going to have a heightened level of concern with that situation. Okay? That we still want them connected with a mental health professional, but they're still in the thought realm. We haven't done anything yet. Next, we have suicide preparatory behavior. And preparatory behavior is when we are starting to move into actions. This is when folks start doing anything that they are putting the pieces and parts together where then they would be able to have lethal means and actually make a suicide attempt. So examples of this are things like someone goes to the medicine cabinet and they gather up all of their pills and they've got them all lined out because they want to see how many they have. Or someone who goes to the hardware store specifically to buy rope because they've decided that they want to hang themselves. So at this point, they've not done anything yet to make an attempt, but they are having goal-directed activity to put the pieces and parts together where they would be able to do that. And so now we have moved out of thought realm, we're into actions, and that is a point where we are starting to view this as an emergency situation. We want to have a more heightened sense of urgency and a heightened response to that. And then we have suicide attempt. And this is for someone who has actually followed through on their plan. They have actually taken action to end their lives. One of the things that's important that I want everybody to know is that if someone classifies their behavior as a suicide attempt, that's what we go with. It does not have to be something that we know could have potentially been lethal, okay? So if someone tells me, I took 4 Tylenol as an overdose because I wanted to die, we classify that, we consider that an attempt because they're telling us that was what their end result was that they were going for. It doesn't matter that we know that an individual is not going to be able to die from 4 Tylenol. Okay? So it doesn't have to be lethal. It just has to be what they're telling us that was their goal was. Okay? And then my last little bit is the word suicidal. This is my pet peeve. So suicidal means marked by an impulse to commit suicide. There's intention involved in the term suicidal. It implies that someone has intent. But this is a word that we see thrown around all the time and associated with someone who's just having thoughts, suicidal. Maybe it's somebody who's just upset. We haven't even asked and found out. Suicidal. So I often get people sent to me, referred to me, calls passed on to me and say, I have a suicidal patient. But when I talk to them, that's never come across their mind. They're upset. They're mad. Okay? So I want us to be really mindful about the terminology we use and try and reserve suicidal for just those cases where you're concerned that someone actually has some intention. Because we don't want to classify folks or respond as something that it is that it isn't. Okay? So that's my pet peeve. Thank you for indulging me. All right. So we've talked about thoughts and that thoughts can occur all the time. Some folks just hang on to them. But suicide crises actually pop up, unexpectedly, pop up quickly, and resolve pretty quickly. Folks can have thoughts all along, never hit a crisis. But when they hit a crisis, it's a surprise event. Okay? The important thing to remember about the crises is not to minimize the seriousness, but in a lot of ways, this is like folks who try and quit smoking. You have an urge for a cigarette, and if you don't give in to that craving and smoke the cigarette, that craving goes away. So similarly, with suicidal crises, it is going to resolve itself if someone doesn't act on the impulse to take action. This is actually where reducing access to lethal means is a key. That is the single most effective preventative factor for an actual crisis. So if I have a crisis pop up real quickly and I have a loaded handgun in my nightstand and all I have to do is one action and there I've got something in my hand that can be lethal, that's scary. We're potentially having a very bad outcome. But if there have been precautions taken and we have a series of barriers and delays and all sorts of things that have to happen before I can get all the pieces and parts put together to have access to something lethal, that's time built in that all sorts of things can happen, okay? Someone can come home from work, the phone can ring. I literally had a woman tell me that in the process, in the middle of her suicide crisis, the dog barked. Something set off her dog and the dog started barking, and that simple thing was what made her stop for a minute and say, oh my gosh, what is going on? So if I have someone in a suicide crisis and they have to go to the gun safe and they have to remember the combination and then they have to take the gun out and then they have to go somewhere else to find ammo and it's locked too. They have to do all of these steps to put stuff together. That's all sorts of time that something can happen that can stop that crisis or avert them finishing that action. Okay? So now I've talked about a bunch of scary, sad stuff, and I want to now give you a positive stat. 85 to 90% of people who survive a suicide attempt do not go on to die by suicide later. If they have tried one time, that does not mean that their eventual outcome is death by suicide. 85 to 90, that's huge, guys. Most of us fiddle around with numbers. That's a huge amount of folks. And that should make us feel very positive and very hopeful, because that says, hey, this is preventable. This can be helped. There are things that we can do that make a difference for folks. And that's kind of what I want us to latch onto for a while. So now we need to talk about what we need you guys to be able to do. And the first thing is we need you to be able to recognize where there is potential risk, where there's distress in folks. And then once you do that, you need to know what to do about it. How to get somebody in front of someone else that can do an evaluation and can find out exactly what we're dealing with and can assist somebody in staying safe. So we talked about suicide and suicidal thoughts. That is an expression of emotional distress, okay? So I'm looking across the room. Y'all look human to me, and I'm assuming you interact with other humans on a regular basis. How do you know if somebody's in distress or upset? What signals do you get when somebody's upset?
They raise their voice.
They raise their voice, okay?
They're either angry or sad, or they trying to express whatever they're feeling.
So we've got angry,
Crying.
sad, crying, struggling to express what they're feeling. Okay, what else? Don't make her do all the heavy lifting here.
Sometimes they're quiet and they don't say anything.
Right, sometimes they're very quiet and they're saying nothing, you can't get through to them at all, and that's a signal. Okay, anybody else have any thoughts? How do you know when folks are upset? They might tell you. Yeah, we do have some folks that are very good at expressing exactly what they're feeling and what their needs are. So, and that's awesome when that happens. There's no guesswork involved. And we need to believe them. That's the other thing we need. We need to believe them. Okay. So you guys got a lot of these. The crying, that kind of stuff. Angry outbursts, angry. That indicates distress and upset. We don't always have to be sad. We got distress here if somebody's angry. And we deal with a fair amount of folks that get pretty angry around here. So I think most of us should be able to recognize that. We've got pacing, agitation, any kind of physical activity like that implies that they're upset, they're agitated, they're irritated. And then some of the more subtle things that we've tapped into, if somebody's really kind of like slumped and hunched and almost like they're trying to fold in on themselves, almost like they're trying to create a shell. If they are staring off into space, just completely zoned out, not daydreaming about being, at the Bahamas instead of work, but, almost like they're just in their head too much, that's a signal. These are things that are not items that take any kind of special certification or skill set or training to recognize, right? These are things that I like to categorize as falling into the category of something ain't right, okay? Because that's really the beginning of what we need to do, is tune in to something going on with some person and saying, something ain't right here. Something ain't right. So these are your something ain't rights. Here's a few more. Hopelessness. This is a huge one. And it's one that I think we actually kind of gloss over pretty quickly. I found as humans that we tend to like complaining. We do. And we like complaining a lot here. For some of us, it's like a hobby, right? And then we like to complain in groups. We want everybody joining with us, right? Misery loves company. And so we've all said stuff like, oh, why do I even bother? It's not going to make any difference. We've all said that kind of stuff, right? Some of us maybe more than others at times. But if you have somebody that you're interacting with, that is their constant dialogue, that's everything all the time, that is communicating a fair amount of hopelessness. And if somebody truly has no hope, what is it that's keeping them here? Okay? So when we have conversations with folks, I want you to keep into your back of your mind that if you're tuning in to that this is always what's going on, to maybe step out of the misery loves company and joining in that and think, is this going beyond just being you know, enjoying the complaining and frustrated with what's going on. Is there more to it than this? Anxiety, sleeplessness, mood swings, these are all contributing factors to distress. Sleeplessness is huge. I mean, we got lots of folks that struggle with insomnia for various reasons. And we know that if folks are going repeatedly, you know, days without any or very little sleep, I mean, everything starts coming unraveled. We got to have our sleep. So it's not just our mood and our ability to cope. Everything's coming undone with sleeplessness. And so we need to tune into that. Feeling like there's no reason to live or feeling like a burden. You all, this concept, this theme of feeling like a burden is probably the single biggest tell for someone that has an impending suicide attempt, an attempt on the horizon. When you talk to attempt survivors, consistently they will tell you that they were in a place in their head where they truly believed that they were a burden on everybody else in their lives, and that they would be doing a service to remove themselves and relieve their family of that burden. So that is a consistent theme. It's very important to tune into. Engaging in risky activities. So if you've got folks that are like driving fast and recklessly, weaving in and out traffic, telling you about this kind of stuff, you know, going certain places in town at certain times of night where you know nobody should be there if you're not up to no good. I actually had a fella that I worked with that was actively confronting drug dealers, like in their face, you know. So they're engaging in activities that are inviting danger, inviting harm. This communicates that they are not valuing what happens to themselves. So that's something definitely to be concerned about. An increase in alcohol or drug use. We have a fair amount of people who consistently use. That's part of what they do. And so if we see a drastic increase, that indicates something's going on, right? But I'd also like you to tune in that if we have somebody who suddenly stops using, and not because they want to be in a recovery program. So if you've got someone that's a consistent user and they suddenly stop, that is a risk factor for suicide. A lot of people think that folks make attempts when they're under the influence, but when you talk to attempt survivors, when you look at, unfortunately, toxicology reports from autopsies, they're stone cold sober. Because if they've made that decision that that's what they want to do, they want to be fully in control. And so suddenly stopping, but not because they want to be in a recovery program, that's a signal that something's going on. And of course, it's pretty common and typical. We expect one of the signs to be withdrawing from family and friends, isolating, giving up the things that we typically enjoyed. That's a sign. And then basically what this boils down to is any change in a standard pattern of behavior, anything that becomes different, that's a signal something ain't right, okay? If they've been rocking along and they've done something the same way all the time, this is always what they do, and we have a sudden change, then something's going on. So what do we need to do when we recognize that something ain't right? We need to be humans with compassion and concern for other humans. Again, no special training involved. And we need to ask them how they're doing. We need to ask if they need any help. Is there anything that we can do? We need to check in with them. And if we have a situation where we really think that the concern is for suicide risk, we need to ask them specifically about that, okay? We need to let them know that's where our level of concern is. We need to ask, are you thinking of killing yourself? Are you thinking of suicide? That makes a lot of people anxious to ask that question. So here's a myth. A lot of people are anxious about asking that question because they're afraid that that's going to set into motion a chain of events that they didn't anticipate. Asking someone if they're thinking of suicide if that's nothing that's crossed their mind, you're not gonna give them the idea. They're not gonna add it to a to-do list, okay? But if you ask someone if they're thinking about suicide, and they have been, that gives them permission to talk about it. That opens a door for them. The stigma that we talked about earlier, that shame and that guilt and that embarrassment, folks that have thoughts of suicide, they know that. They feel that too. And so a lot of times you will have people who are hesitant to share that that's what they're feeling because they don't know what kind of reaction they're going to get. You know, some folks have told me, you know, they're going to think I'm crazy. You know, some are worried that you won't really take them seriously. And then commonly we hear the fear is if I say anything, they're going to lock me up. Okay? And it doesn't always require that. So do not be concerned that if you identify that as a concern and you ask about it, that you're going to make something happen that was never intended to happen. But you know what? We don't do this. We are lousy at this. I've been at the VA almost 9 years, and I tell people all the time, this is the chattiest place I have ever worked. I mean, you walk down the hall, and you better make eye contact and say hello and greet everybody that you see. I mean, everybody does that. I mean, it took me a minute to get used to, not that I'm an unfriendly person, but it was just like, wow, it's literally every person I see. There are folks that I've said hello to and chatted with for years. I have no idea who they are, okay? I don't know their names. I don't know where they work. But I have probably talked to them 3-4 times a week, you know, for 7-8 years. If I saw one of those folks and suddenly they had a cast on their leg or an arm brace or something like that, I would, without a thought, I mean in a split second, say, oh my gosh, what happened? And I would inquire how they were doing. In a minute. But when we recognize emotional distress in that same sort of situation, that is not our first reaction to immediately check on them. It's not. We have the gut feeling. We recognize that something is not right. What on earth is going on? Can we box? I don't know what that is. We recognize that something is not right. And then we start talking ourselves out of doing anything about it. Okay? And there may be a number of reasons why we do that. We might think, you know, I don't want to be in their business. They're going to get all offended. They're going to be mad that I'm like, you know, I don't really know them that well. We might think, oh, somebody else that knows them better, they'll ask. I'm sure a friend of theirs will make sure they're okay. Sometimes we don't ask because we recognize value in that other human. We think, oh, they've got a good job. You know, I see them talking to tons of people. I see them out in the community. We recognize that their existence on this planet is important. And so we don't even think that suicide would be on the table. The problem is if they are thinking of suicide, at that point they can't recognize their own value. They can't see that at all. And so don't talk yourself out of checking on someone because you think there's no way that suicide could possibly be an option. But probably the biggest reason why we don't ask is we're afraid of the answer. We really are. We're afraid that someone will say, yes, I'm a mess right now. And that then we might say something wrong or do something wrong or not do enough or do the wrong thing and something will happen to that person. And so it's protective for us to just talk ourselves into really probably nothing's wrong. Therefore, I don't need to check on them. Okay? But I need y'all to get over that. I really do. I need us all to get over that, to overcome that inertia, that self-doubt, that self-concern. And when we see somebody that's having some emotional distress of any kind be willing to put ourselves out there and check on them. So let's say you do that, and they tell you, yeah, I'm a hot mess right now. What do you do next? I just need you to be a human. Again, no special skill set. Listen. Be compassionate. Be present with them in the moment, okay? There's not a set screening questionnaire you have to go through. There's no template you have to complete. I just need you to be another human showing concern for another human, okay? So let them talk. At the same time, I need you to recognize the situation is serious and that we're going to want to make sure that they get in front of somebody who can figure out exactly what it is that we're dealing with. Sometimes folks will tell you, oh yeah, I'm a hot mess, and then immediately start kind of backtracking. Oh, it's really not that bad. They'll really start minimizing it. Don't get sucked into that, okay? There was still a concern. We still need to stay with that concern and make sure we know exactly what it is. It's still serious. We don't need to pass judgment on them. Not saying that most folks would do this overtly, but one of the things I want you to be aware of is that with mental health or behavioral health concerns, the way we see them, most of the time the way they manifest is with emotional responses, emotional dysregulation. And a lot of times, what's in the back of our mind, our common way to think about, respond to that kind of stuff is, well, man up. It's not that bad. Use your willpower. Come on. We expect that people can control that. All right? We don't act that same way with physical stuff. We would never cross our mind to treat a physical ailment or challenge the same way. We wouldn't have somebody who's having a major high spike in their blood pressure. We wouldn't tell them, sit down, lower your blood pressure. My gosh, what's wrong with you? We would never think about that. But we do that with emotions all the time. And there are times that people can settle themselves down and control their emotions. But there are times that they don't have that control over it. And anticipating and kind of demanding that they be able to like respond and handle that on their own is only reinforcing stigma and shame for folks. The other thing that I want us to remember is that help is available. Reassure them that help is available. That little piece could be the one thing that provides that little nugget of hope in the moment. Okay? Because suicide is preventable. Remember that 85 to 90%? Okay? I tell folks all the time, the way you are feeling right here, this moment, this does not have to be the way that you're feeling forever, or even tomorrow, or next week. There are things that can be done. There are things that we can do to help you and for you to help yourself so that you feel better. They need to know that's possible. And then we need to recognize that suicide risk, our ability to handle distress, our ability to cope, for all of us, that's fluid. That's very changeable. So somebody could be in a really fragile position one day, and next week it's a completely different scenario. All sorts of other factors have come into play. On the other hand, it's our ability to cope does the same thing. You know, there are some days that I come to work and I feel like, man, I'm on it. I'm hitting on all 4 cylinders. Come on, bring it on, bring it on. And then there's some days that I'm here and I think, oh, if it is one more thing that is just going to push me over the edge. Our ability to cope is flexible too. All right. So now we've overcome our own inertia, and we've checked on people, and we've done everything that we need to do. We're reassuring, we're supportive, and we know they need to get in front of somebody that can do an evaluation, that can figure out exactly what it is that we're dealing with and what needs to happen. There are mental health providers located at Charlie Norwood all over the place, and you may not be familiar with where everybody is. Downtown, even though that's not the designated place with mental health, we have mental health providers downtown. In the spinal cord unit alone, there are 5 psychologists. Okay? We have a psychologist and a psychology tech in specialty care. We have an emergency room that is staffed 24 hours a day, and it's staffed 24 hours a day now with social work. And those are the folks that are utilized to do those initial mental health evaluations for folks that present. We also have 2 nurse practitioners that are based here in the outpatient clinic, and they alternate going downtown and consulting in the specialty care beds. They do rounds with the docs and the treatment teams. And they're looking for folks and assisting with, let's say, if you have someone in a bed that has just had an appendix removed. But they also have a history of depression. They've been on antidepressants for years. Maybe we need to do some consultation to make sure, is this still the right med? Is it going to interact with anything else? This is a high-stress time now. Do we need to increase dosages? That kind of stuff. They consult on those cases. They also consult on cases for folks that are in medical beds where there's concern for suicide risk, and that they'll go in and they will do risk assessments and advise the treatment team about stuff that needs to happen. So we do have mental health access downtown. Uptown, we got mental health providers all over the place. Okay. We have mental health providers in the primary care clinics. It's embedded in primary care. We have a psychologist in our blind rehab. We have psychology in traumatic brain injury med rehab. Our domiciliary is a general mental health DOM, and so it's got tons of mental health providers there. Our CLCs, our community living centers, have mental health. There's a psychiatrist and psychologist that covers all of that. We have specialty care mental health clinics. We have our substance use recovery center, and we have our trauma recovery center, our PTSD folks. So we have all of that in addition to general outpatient mental health clinic and the inpatient psychiatric unit. The other thing I'd like you guys to know is that on nights and weekends and holidays, any of the off times, there's a group of psychiatrists that we contract with that come in and cover those off hours. So literally in this particular building, there is a psychiatrist in this building 24 hours a day. Then we always have, as our 24-hour emergency backup, our Veterans Crisis Line. There's always 911, and then our emergency room still. It's 24 hours receiving access for care. So there's a fair amount of people that you could snag if you've got somebody that you've identified needs some sort of an evaluation. Okay? So what do you need to do specifically? If you are downtown and you are working with a veteran that's in a medical bed and there's a concern about distress or suicide risk and you need an evaluation, we need to make sure the charge nurse knows. And they're going to let the attending know, and they're going to begin taking some action. They're going to put a sitter in the room so there's somebody one-on-one. We never want to have anybody that's in distress. We never want to have them left alone. Okay, so they're going to have somebody one-on-one. And then they'll probably move some equipment and stuff out of the room, stuff that would be within easy reach. We want folks to be safe. And then they're going to request the mental health consultation, folks to come in and talk with that veteran and figure out exactly what it is that's going on. If you are downtown and you are working with somebody that is out and about as an outpatient and you have concern about emotional distress, suicide risk, we need you to get them to the emergency room. And we need you to escort them. Again, anyone in distress, we're not leaving them alone. We don't just say, go down to the emergency room and tell them what's happening. We're going to take them with us. We're going to walk along, being reassuring the whole way. When we get to the emergency room, whomever is there that is receiving patients, whether it is a clerk or a nurse, we need to clearly communicate why we're there and what our concern is, okay? We need to let them know there's a concern about suicide and that they need an evaluation. Because that's not a person that they're going to have sit in the waiting room. That's somebody they're going to go ahead and bring back into the emergency area and have them set up in a room and have somebody with them and start following their safety procedures as they get that evaluation. So we need to be really clear with folks why we're bringing veterans to them and what our worry is. If you were uptown, we do have a few places here that do have medical beds. We have our CLC, we have our DOM, folks, our residents, they stay here. We have a few beds in blind rehab, we have a few beds in medical rehab. So it's a similar procedure uptown if you've got somebody that's in a medical bed. The nursing staff, they need to know what's going on. If you have somebody that's an outpatient and you're in one of those clinics that has a mental health provider, that's who you snag. They're there, they're handy, that's why we put them there. So if it's in primary care, grab that one, grab that psychologist, they're close, all right? Anything else, or even if you forget and say, I don't know if there's a mental health provider here or not, bring folks down to the outpatient mental health clinic, which is located in 1F. And it's the same process that you would use for the emergency department. We want you to escort them. We want to make sure you let folks know that the concern is about suicide risk, that they need an evaluation, because they're going to immediately start that process. They're going to call one of the psychiatric nurses in the unit who's going to come get that patient, begin that evaluation, and make sure that they're safe. We do have a couple of policies and procedures for more emergent situations I want to make sure you're aware of. Code Gray is our behavioral health emergency. These are for situations where there's a real potential for danger. So if you've got somebody that's really out of control, if they are actively trying to harm themselves or harm somebody else, we got a behavioral health emergency and you would want to do a Code Gray. You wouldn't want to physically intervene yourself. If you have somebody that's willing to go with you to see someone for an evaluation, even if they're like loud, upset, hysterically crying, if they are willing to come along, that's not a Code Gray. Okay, Code Gray is for folks that are in danger and that aren't cooperating with getting assistance. Then we have our Code ADAM, our management of wandering and missing patients. So this is what we implement when we have folks that are at-risk people that all of a sudden, poof, they disappear. They disappear from the clinic, they disappear from their bed, they were there 1 minute, now they're gone. They checked in and now they're gone. When folks are at risk, we don't want to automatically assume that they just went to go get a snack or something. We want to check on them and make sure that they haven't gone somewhere or done something that's going to cause them to be unsafe. And so when Code ADAM is implemented, the unit's going to kind of go on shutdown. Everybody's going to be alerted. They're going to start looking for the missing person. There's going to be overhead paging. The police are going to be involved. It's kind of all hands on deck to find that person because they're potentially at risk and we need to make sure they're okay. And this is what we consider at-risk folks, all right? This is how we define it. If they have been legally committed or have a court-appointed legal guardian, those two right there, that lets you know at some point, whether it's temporary or permanent, at some point it's been legally determined that this person doesn't have the ability to make their own decisions. Their judgment is not there. And so if judgment is impaired, then that automatically puts somebody at risk. If they are considered dangerous to self or others, if we have already evaluated them, let's say we have been evaluating someone, we have determined that suicide is an imminent risk and we're trying to get them admitted to a hospital and they go poof, we would code ADAM because they are an at-risk person. If they are disabled due to a mental disorder, if they lack cognitive ability, like our folks with dementia, they have cognitive impairments. If they have any kind of physical or mental impairment that increases their risk of harm to self or others, anything else that's going on, that there's that potential, we consider them an at-risk person. And one of the things I want you to remember, this term of at risk for harm to self or others, it does not have to be intentional. Some people hear that and think that that means actively suicidal, actively homicidal. It could be the folks that you know, our demented gentleman that isn't aware of his surroundings, you know, doesn't tune into that kind of stuff, he wanders off. He's not capable of keeping himself safe. He's at risk to self-harm because of that impairment, okay? So it does not have to be an intentional risk, all right? Okay. I've been talking a lot. Whoop. So now I'm gonna turn it over to my colleague for the next little section. Yes? Okay, so the question is, what if we have somebody on the phone that's in distress or is potentially suicidal? What do we do then, okay? And what we need to do is we've got to put eyeballs on them to make sure that they're safe. We're on the phone with them and we have to have somebody check on them. So if you feel like they are at imminent risk, especially if they're alone, there's nobody else there that can help keep them safe, then we need to send out a welfare check. And the way we send out a welfare check is through our VA police, okay? We don't need to Google, you know, all the different dispatch numbers for law enforcement. So we contact our VA police and let them know that we need a welfare check. As much information as we have that we can provide them, the better. So we, of course, want the basic demographics, like where they're located and who it is, and if there's a number, phone number, things like that. They like to know if we have any idea if there's a weapon involved, because they're going to want to know what they're responding to. If there's any other thing that would clue them into risky situations, that's helpful. If this person is under the influence, if there's a serious medical condition like diabetes or something, something that could potentially affect their behavior. You know, if somebody's blood sugar is low, you know, they could behave in a way that maybe is slightly erratic or things like that. They'd kind of want to know what to expect. If you don't know those things, you don't know those things. But we want to tell them as much as we can. And then they contact the appropriate community authority and get them out there to check on them. The trick with the phone, though, is you need a partner. So, because we'd ultimately, if we can, we'd like to keep the veteran on the phone. And we'd like to have a partner that's contacting the police and relaying the information to the police. And so a lot of folks use our instant Skype sort of a thing to holler for folks. Some folks do landline cell phone, you know, whatever creative way you can think of to say, come here to my office, come here to me, I need some assistance with a veteran, then that's what works best, and you kind of tag team it.
So at the end of the day, we really want our veterans to be safe. We really want our staff to be safe. And we want to empower you so that you know that you can ask for assistance when you need to. When a veteran is trying to leave against medical advice, you need to know that you can call and ask the police for assistance. That any clinician in this building can ask the police to assist them with detaining a patient. That was what came out of, that's part of what came out of the RCA, that the staff didn't realize that they could use the resources here at Charlie Norwood. So you can, every clinician can do that. So it clearly states that if a person is attempting to leave against medical advice, we can temporarily tell the police to detain the patient while we get the 1013 in place. So we're going to err on the side of being cautious. Now, the first question that always comes up is, who can do the 1013? So the people who can do the 1013 are your licensed physician. Anybody who has MD behind their name can do the 1013 order. You know, sometimes we get a little pushback from certain disciplines, but any medical physician can do the 1013. Sometimes they think only the psychiatrist can do it, but that's not true. Any medical physician can do it. Any licensed psychologist can do it. Any clinical social worker or clinical nurse specialist can also do the 1013 order. 1013 is the order that allows the police to detain the patient. So, but they have to have an evaluation by one of these providers. And the clinical nurse specialist can't be any clinical nurse specialist. It has to be the clinical nurse specialist that has the specialty in psychiatric or mental health nursing. So your general family nurse practitioner couldn't do that. Only the person who has the psychiatric mental health specialty can do those things. So we really just want our patients to be safe, and we want our staff to know that you can ask for assistance when you need it. It is better to err on the side of being too cautious and encouraging, or at least getting that evaluation so you can determine what needs to happen with the patient next. Oh, one last thing. Okay, so the VA police standards. You know, I'm fairly new at the VA, and one of the things people always say to me is, show me in policy where it says that I can do X, Y, and Z. So this is the VA police standards, our policy, and this is the actual verbiage that says, a patient who's been determined by the clinical staff to be a threat to themselves or a threat to somebody else are not, hear me well, not allowed to leave the premises voluntarily. And that covers the ED as well as the urgent care clinics, but it applies to anywhere on VA property. So if he's in the parking lot, if he's in the hallway, if he's in the ED, he or she, we can detain those patients until we can get that evaluation by those appropriate people. Now, it also includes patients seeking or requiring treatment that are identified under the influence. So when they're using substances, we can detain them too, because we got to make sure they're medically stable to be released to go home. So that evaluation, that is a reason why you can say to the police that I need for you to detain him so we can get that evaluation in place. Now, in your TMS, you will be given a TMS to attest that you've seen these two slides. In fact, mine came this morning when I happened to be looking at my TMS account. So I had those two slides in my TMS, and I have to sign that yes, I understand the information and that I know that I have this ability to ask the police their assistance in detaining a patient. Sure.
We're in pharmacy,
Yeah.
and we have a physician who is telling them they're AMA. They're wanting, the patients want to leave without medical advice.
Mm-hmm.
We try to not send them out, but then we're told we have to give them medication even though it's not doctor's advice to give it. But they're writing orders, so why are you writing orders if you're not wanting them to leave?
Right, like you're assisting them in leaving is what I hear you saying. Right, well, now, that's a different issue. The first part of the problem is the physician, if they're leaving against medical advice and the physician thinks they're safe, that's one thing. But if the physician thinks they're unsafe, then you need to do he or she needs to do the 1013. So that's when the evaluation can, we can determine what's one way or the other.
That's the provider who needs to do that, right?
Right. The pharmacy doesn't need to do it. The provider has to do it. So we can't make the provider do anything. But if the patient is unsafe, that's why we get the police to detain the person so that evaluation can be completed.
I wonder if, in that scenario, if the nuances are, it's against medical advice. We would prefer, and it's in your best interest to stay here and follow the course of treatment.
Mhm.
However, you are not at risk of danger if you leave, and therefore we will agree to the discharge against medical advice, but we're still going to prescribe medication because we're still going to continue your care. I wonder if those are the nuances in those kind of situations.
Right. Well, it's really about just evaluating that patient and making the best determination possible. So part of what this training was about, so that people would be informed about what they can and cannot do. And like I said, it's all about safety of the veteran. When we don't know, we don't know. But we're going to do the best we can to evaluate the situation and make the most appropriate decision. So that's what's happening now. So they'll be coming in your TMS if they're not already. There are these 2 slides, Will, and you'll be attesting that you have knowledge of these 2 slides. The other thing that's coming is the mock drills. And part of why we are doing the mock drills is because when you don't use it, you lose it. So we want those situations familiar to you. We want you to know how to respond. And every situation is not going to be black and white. It's going to be, as I say, shades of gray. So what would you do? So, like I said, whenever in doubt, err on the side of safety. Okay?
All right, we're at the point where we're wrapping up here, and so I just want to reinforce a couple of things. For most of us, the idea of starting to really recognize distress, engage it proactively, it's a little uncomfortable, okay? And for a lot of us, it's stuff that we haven't done and we don't typically do. And so I just want to reinforce that practice makes perfect. The more you do something, the better you get at it, the more comfortable that you feel. Things are going to be uncomfortable when they're new, all right? The other thing that I want to reinforce is we've talked about all sorts of scenarios and we've talked about procedures when we check on people and they let us know, yes, I've got a problem, and how to facilitate getting help. Don't discount the benefit and the positive influence that could happen if you just check on somebody and they say, no, I'm fine. They may not be. We may never know that. But the sheer fact that you showed compassion and concern for that person may be the one thing that has a gigantic impact that changes everything. We are about to show you a little video clip to wrap this up. And it is a video clip of a man named Kevin Hines. And I was very lucky to be able to hear him speak this summer and tell his whole story. Kevin Hines is a suicide attempt survivor. And in his story, what he shared with us is the day that he made the decision that he was going to make an attempt, he made a pact with himself that at any point in the process, if anyone stopped him, asked if he was okay, checked on him, expressed any kind of concern, he was not going to follow through with his plans. But nobody did. You got it?
We have lost far too many lives traveling the path to this day.
Since 1937, over 2,000 people have died at the Golden Gate Bridge. I feel lucky to be alive every single day. Of the thousands that have died off the Golden Gate Bridge, I am of the 1% who have survived. So I was born on drugs and premature. And then I bounced around from home to home. Nobody wanted to keep me because I was sick. And I got lucky. I landed in the home of Patrick and Deborah Hines. I had a great childhood. I thought growing up that everything's gonna be great. And then at 17, it all came crashing down. If you can imagine feeling that everyone around you is out to get you, trying to hurt you, and trying to kill you, and you believe that to be the truth. From the extreme paranoia, I exhibited symptoms of mania. From the mania came the hallucinations, both auditory and visual. And so with that and the bipolar disorder, I just was spiraling out of control. I vividly remember writing my suicide note. People don't get it. Like, I thought I was a burden to everyone who loved me because that's what my brain told me, because that's how powerful your brain is. I got off the bus. I walked slowly down the walkway of the Golden Gate Bridge. You know, people rode by me, drove by me, walked by me, and a woman approached me and she said, "Will you take my picture?" She said thanks and she walked away. It was that moment I just said, nobody cares. The reality was that everybody cared. I just couldn't see it. I ran forward and using my 2 hands, I catapulted myself into free fall. What I'm about to say is the exact same thing that 19 Golden Gate Bridge jump survivors have also said. The millisecond my hands left the rail, it was an instant regret. And I remember thinking, no one's gonna know that I didn't want to die. In 4 seconds I fell 75 miles an hour, 25 stories, and I hit the water. I was in the most physical pain I had ever experienced, I have ever experienced. The Coast Guard was amazing. He was just so freaked out that I was alive that he just dove in and brought me on board. The guy said, do you know how many people we pull out of this water that are already dead? And I said, no, and I don't want to know. The guy put his hand on my forehead, said, kid, you're a miracle. My father took 1 step into the hospital room, and I looked up at him and I said, Dad, I'm sorry. And he said, no, Kevin, I'm sorry. And if you think about it, both of our immediate reactions were guilt. Guilt that didn't belong to either of us. And even though I didn't die, I caused people a great deal of grief and pain. Just the day of my attempt still sits within them today. I asked my father if he still feared my death by suicide. He said every time the phone goes off, his first inclination is Kevin alive. I had that impact on my dad. So after the jump, the road to recovery was pretty long. I had 7 psych ward stays in the next 11 years. I still have all the symptoms I ever had. Mania, depression, psychosis, hallucinations, all that's still there. I just know how to cope with it and I know how to beat it. I built a support network over these years of treatment so that I wouldn't be fighting this alone. So like, it's okay not to be okay. It's not okay not to ask for someone to back you up. To the families who live with the loss or losses of loved ones, they didn't do that to hurt you or destroy your life. They took their lives because they were struggling and in a great deal of emotional and mental pain. Suicide, mental illness, and addiction are the only diseases that we blame the person for perpetually. But people die from suicide just like they die from any other organ diseased. Today, no matter the pain I'm in, no matter the struggles I experience, I do believe that life is the greatest gift we've ever been given. And if you're suffering mentally, don't wait like I did, sitting in denial for so long. Because recovery happens. I'm living proof.
He has a song that the title of it is The Hotline Number. And it's a very powerful song, and it starts out with, the voice of someone. It's from a person's point of view who wants to die, who's contemplating suicide. And through the course of the song, he gets help, he talks to people, and by the end, he wants to live. He's feeling positive about things. And in the performance in the Grammys, toward the end of the song, there were a whole bunch of people who filed onto stage behind him. They were all wearing white T-shirts that said either the hotline number or said you were not alone. And these folks were attempt survivors. And when the camera focused on Logic, dead ahead, directly over his shoulder, standing behind him, was Kevin Hines. He was on that stage too. So one of the things that I want you guys to think about and to really be reinforced here is, yes, we've talked about procedures, we've talked about all sorts of things to do, but please don't discount the power that you have as an individual by just expressing concern for another person. It could change the trajectory of someone's entire life, because it would have for Kevin Hines. So, thank you all so much for being here today, your participation. We all appreciate it. Please fill out your evaluations. So, thank you so much.
Thank you.